Hello there, welcome to La Rochelle Hospital, where we have shot a film to depict the use of the radiation protection cabin Cathpax for interventional cardiology. Dr. Jan Valley is the first doctor around the world to use it on a daily basis. The radiation protection cabin Cathpax, developed and manufactured in France, has a lead equivalence of 2 mm, which guarantees an optimal radiation protection. It protects the operator from head to feet and could obviate the need for wearing lead aprons in case of orthopedic troubles. The setup of the sterile kit whose purpose is to guarantee the asepsis is quick and easy, taking less than 2 minutes to set up.
I work in the Interventional Cardiology department of the Rochelle Hospital. Our staff includes 3 doctors, myself, Dr. Charlotte Trouillet, and Dr. Ludovic Meunier. We perform up to 3,000 procedures per year, including 1,400 to 1,500 PTCA, and our referral center for the treatment of acute coronary syndrome. I have been performing coronarography and angioplasty procedures for more than 20 years. In the aim of a closer medical monitoring of my exposure to ionizing radiation, I had to put in place increased preventive measures. At the same time, I heard about the radiation protection cabin by my colleagues in electrophysiology. Then we decided to try it. Our first trial began in autumn 2013. At that time, we had some concerns about the multiple C-arm views, such as LAO. Ultimately, it worked well from the beginning, and as we went along, following the flow of the emergencies, standby duties, and weekly schedule, we were able to validate step by step the different techniques that we perform here in La Rochelle. The simple diagnostic procedures, the simple angioplasty procedures, the complex angioplasty procedures using rotobladder, the endocoronary imaging, FFR, coronary pressure monitoring. It has been nearly 10 months since we started using it, and I cannot imagine working without it now. Now that I have totally embraced it, I can see that my radiation doses have substantially decreased over the past 10 months. And with practice, we can easily get used to the cabin, either for right radial access, which remains our favorite access here in La Rochelle, or the right femoral access. Left femoral access may be still hard to achieve with larger patients. For left radial access, we have good success by crossing the arm over the lower abdomen and affixing it with adhesive tape. Therefore, all access points are achievable with the Cathpax. That is, so far, what I could say about this. I have to leave you now to take care of my next patient.
The first case to illustrate the use of the radiation protection cabin is a coronarography procedure before cardiac surgery for valve replacement.
We have seen the left coronary artery. We're going to see the right now. Here we are. It is finished, madam.
During this simple coronary diagnostic with right radial access using radiation protection cabin, you can see average procedural and fluoroscopy times, hereby procedure time of 10 minutes and fluoroscopy times inferior to 3 minutes. The radiation dose measured by the operational dosimeter during this procedure reaches 0.03 microsieverts. To show you the feasibility of using the radiation protection cabin during complex procedures, we have chosen to present a case of right coronary artery resistant stenosis treated by rotablator angioplasty.
A 66-year-old man having coronary bypass graft in 2008 and a positive stress test at 120 watts from last spring. On the diagnostic coronography imaging, bypass of the left arteries are good. Mammary artery to the marginal and the cephen to the marginal. On the other hand, the right coronary artery hasn't been revascularized. You can see here proximal calcified eccentric stenosis at the end of the first segment with a massively calcified artery and a nice downstream blood flow which is pathological at the level of the intraventricular posterior artery, followed by a good downstream flow. We will perform rotational angioplasty with a rotoblator atherectomy system on this proximal eccentric stenosis at the genius superiors, and then we will target the distal stenosis of the posterior interventricular artery. We will treat two sites, this one first and this one. So, we introduce a second guide wire along the first one, which is the guide wire of the rotoblator. Then we take a whisper extra support guide wire.
Stop. Ou pour voir. Oui. Ouais, c'est bon.
As here, my guide wire couldn't rove to the distal section of the interventricular posterior after passing the proximal dissection. We will reintroduce the coaxial balloon over the rotoblator guide wire at the end of the IVP, and we will reposition the balloon over it while the dilation guide wire will be withdrawn. Fluoro on section 2 after. I can't see it well. The balloon. In order to pull the guide zilla to the second section, we can inflate here and then pull it back. Here we have placed the first stent to section 2, and now we will place a second stent against the first, more proximally. Here it is finished. You can see exposure is less than 1 microsievert. This is ridiculously low.
In such complex and long cases for which we had to perform several angioplasty techniques such as rotablator, exchange guide wires over coaxial or OTW balloons, or the use of wide catheter extensions, we can see that the feasibility of the radiation protection cabin is totally satisfying and allow a subtotal radiation protection despite important fluoroscopy durations and radiation doses.